Hi. Welcome to Facebook Live. I'm Dr. Annette Mercatante, the Health Director here at St. Clair County Health Department, and we have with us our special guest, Dr. Brooks.
Greetings, Dr. John Brooks, Infectious Diseases and Chief Medical Officer, McLaren Port Huron.
So we're going to take our masks off so we can speak more directly, but we're going to make a point so that everyone in the room is masked, and we are trying to maintain our safe distance.
Absolutely.
As we hope you all are as well. Jennifer, what's our first question?
Does the health department have plans to provide antibody testing?
So the question is, does the health department have plans to provide antibody testing? And of course, several weeks ago, the health department did launch its Tuesday testing service, which is by appointment. We do have opportunity to sometimes treat people or test people as they drive up, but that is PCR testing, the swab in the nose. And that is currently the only testing we are planning on doing. That test, by the way, is no charge, and you do not require a doctor's note, and we'll test you regardless of whether you're ill or not. Antibody testing, though, is a very different issue, and there's a lot of problems associated with antibody testing. The greatest one, of course, is that we don't really know what the results mean. And in a community that has a low amount of transmission, the false positive and negative rates can literally be 50-50. So they're very hard to interpret. Dr. Brooks, would you like to elaborate a little bit more on antibody testing?
Bet. So antibody testing, just to chat about that for a moment, is that in medicine we're used to antibody tests. Let's say a common infection like hepatitis. So anybody that's watching that's younger, they've been vaccinated for hepatitis B because they've been doing it for like 30 years. So hepatitis B, we can do a serology test, which is a blood draw, and look and see what are your antibody levels. Do you have antibodies against hepatitis B? What's the level? And if they're there, you're protected. We know you're immune. So that is a really strong correlation between a vaccination or a primary infection and then immunity. We know if you have antibodies, you're immune. The difficulty with COVID, the COVID-19, is that we do not know, and at this point in time we still do not know, if you have antibodies to the infection, are you immune? There's actually some new data from earlier this week that for people that had asymptomatic or mild infection with the COVID infection, when they had a positive antibody at 60 days, their antibody titers were going down or waning. So that is an ongoing concern, is that if people have a really mild infection, if they do get antibodies, number one, does it give them immunity, and will it last? Because that's one of the things that we all want to know about immunity, is that it's long lasting. So antibody testing right now, as Dr. Mercatante said, is kind of murky. We know that there are some antibody tests that are really quite good, that they differentiate or tell us different coronavirus infections. So we want one that's really specific to the current COVID-19 and not old or other coronaviruses. So we can do that, but again, it does not tell us if we're immune or if we're going to have long-lasting immunity, which are things that we always want to know.
So once we have better answers, the answer is as we know more and we know there'll be a direct benefit, we'll certainly look into it further.
Okay, so speaking of testing, maybe Dr. Brooks, maybe you can help with this. When is it appropriate to retest someone who has previously tested positive?
So we're going to talk about the nasal swab. So that's our PCR testing.
Repeat the question too.
Yeah, sure. So why would we want to repeat testing on somebody for COVID-19?
If they already were positive.
Yeah, if they've been positive before. So most of the time we don't. Most of the time it is not required. It doesn't really help us make any specific new clinical decisions. However, there are certain populations that are being tested. Anybody that's going into an extended care facility or a nursing home routinely will be retested before they enter an extended care facility. We'll do that. Some employers do like to have their employees with a follow-up test that is negative. There's some concerns to that. It isn't usually medically required, but some employers have requested that, and we try to comply when we can. But the difficulties with the testing is that it's called a genetic test, so it's a PCR. So it's testing for the genetic material of the COVID virus. The difficulty is little broken up pieces of that virus can live in us or actually just be left in us after the infection is over, and it can be left there for a while. So a follow-up positive test by PCR testing doesn't mean you still have infection. It just means that you still have positive genetic material. And we do not have really good testing at this time to differentiate between live virus and virus that's dead and is just being shed. this is something that we know really well from influenza, especially in our patients that have underlying immunocompromised state, like people with cancer or people with like lupus or other things like that. When they're on medications that affect their immune system, they will shed influenza virus or parts of it for actually weeks and weeks and weeks after they're well, but we have ability to check, and those viruses are always dead. So we don't have that yet with coronavirus. So follow-up testing as of now, unless it's a really specific population, is not helpful.
In fact, is it not true that some of the data that's coming out would indicate that live virus is not detectable often after
10 to 14
10
days.
to 14 clinical days after
Yeah.
you get sick?
Even in immunocompromised
yeah,
people.
so using those, what we call clinical symptoms, to determine when you're safe to go back into the workplace and to be exposed to your friends is actually, I think, a very reasonable approach to take. 10 days after the day you got sick, with 3 days without fever, without any kind of fever reducers, and obviously feeling better.
Absolutely.
And those 3 criteria, really you should be good to go.
Yeah, with that 10-day window.
10 days.
Okay, thank you. All right, a couple questions I've already come across on our feed. U.S. officials believe as many as 20 million Americans have contracted the coronavirus, suggesting millions had the virus and never knew it. Is this considered a good thing? Death rate lower, less potent?
Okay, so the question is numbers. If you have, out of 20 million people, over 1 million that didn't even know they had it, would this in some way affect death rates and case fatality rates? And the answer is yes, it does. That's the way we count all diseases, though. We can only calculate death rates based on, with the denominator based on the numbers of cases we know about. What's more important to understand about how many are asymptomatic and symptomatic is to understand the transmission of the disease in a community. As we go through this, we know that we have to reach a certain threshold of infection before the virus isn't easily transmitted from person to person. And that threshold varies. I saw one article that said 48%, but most infectious disease specialists are saying, what, 60 to 80%?
60%.
Of the population needs to be infected, asymptomatically or symptomatically, just as a whole. So if we know that a certain percentage of infections will be symptomatic, we can kind of think forward and think, okay, how are we doing with that whole population pool? Right now, and I've said this before, from every criteria we've been able to use, it appears that our community has an infection rate overall probably 5% or less. So we have a long way to go.
Yeah, for that piece which we call herd immunity. And that's what we
Okay.
talk about, is that the community has to have a certain number of people that have been infected with the agent, in this case COVID-19. If it's about 60%, then what happens is enough people have had the infection, and we hope are immune to it, that the transmission becomes lower and lower in the community. And that's our goal.
Okay.
We didn't go over the data. Do you want to go over that now or towards the end?
Um,
Slides behind you.
Okay, I'll do it really quick because I really want to get to your questions. So our data, as you know, is always available on our website. This, in particular, is our daily numbers. The thing I want to draw your attention to is the second green bubble that now says we have on an average daily number of 2.4 average daily cases a day. Last week when I was here, I told you it was under 1, it was 0.7. So this is something we need to watch. Not a huge jump, but certainly something we need to watch. Our demographics and such hasn't changed, but nationally they are noting some increases in infection in the younger age groups. Reasons to be discussed later. Next slide. This is our average daily new case count by graph, and again, the blue spikes are those associated with the total population, including our long-term care facilities and our jails, and then the red bars are exclude those populations. And what's interesting, you can see the whole population goes up at the beginning, and then you see that larger proportion of blue spikes that were related to our long-term care facilities. And then we've all come down, and now you can see we're on this other side of the graph. You can see a very subtle increase. And you'll notice that the blue spikes are currently absent. We did a nice job, in my opinion, of bringing those cases down in our long-term care facilities and keeping them down. But if we have the same scenario we had at the beginning, we'll again see those cases showing up further down the line. Next slide. And then this is our percent positivity rate for all of our testing. And we are overall about 6% positivity rate, but for a rolling average this week, It is, I forgot what it was, 3%, which puts us, these are the numbers that the state's using to identify if we're doing better or worse or staying the same. And what these numbers are still putting us in is a moderate risk community. We are not in a low risk community yet. And since there's been this subtle shift, and anecdotally, we have seen more cases in younger people, and we have been seeing cases clearly that haven't been associated directly with a nursing home. So these are changes that we've seen in the last few days that we want to be very careful to follow, so that we don't keep moving into from a moderate to high risk. And then the next slide is what you'll find on our dashboard. So please go to our dashboard. You can look at the numbers, where we're going, and keep track. So that's our data in a nutshell, and we're happy to go over that more with you if you have further questions.
Okay. Next question, and we've had a lot of discussion on this, but this one in particular, why are so many people going without a mask? And should we stop wearing them?
So why are so many people without a mask, and should we stop wearing them? So the answer is from the data that you just saw behind you is that yes, we should still be wearing a mask. So when we talk about masks, there's different ways to look at it, but I do it from the good citizen point of view, is that if I have COVID and I don't know I have COVID because I have no symptoms and I'm going out in public and I don't wear a mask, I can infect everybody around me. If, however, I'm good enough and I put a mask on, I'm being a good citizen and I'm not infecting the people around me. My mask is not really going to protect me very much, but it really, really is going to protect the people around me. So the whole good citizen position, I think, is really, really important. We think about this and other things too. We try to be good citizens, right? Mm-hmm. And so that's one of the things. So when we stop wearing masks as of now, and again, we're still not a low-risk community. We are still a moderate-risk community. It would still be the best thing to do so that we are not continuing the transmission throughout the community. If we can get the numbers down low enough, then we're going to get to the next level, and then we're going to be having less restrictions. Mm-hmm. So we're just not there yet. And the difficulty, we're calling it mask fatigue. And that's the word that we have for it that we're coming up with at this stage. Again, people are tired of this. The whole COVID thing, people are tired of. They're tired of being stuck at home, not doing things. The weather's beautiful, people want to get out. So our suggestions remain that if you're going to get out, if you cannot socially distance, you should put a mask on. And that way, you'll be doing a better job. Now the difficulty is young people, they're going to the beaches and they're going and they're having lots of fun. It's party season, lots of stuff is going on. So ideally, if you're going to be in a gathering, to wear a mask. We know in East Lansing, they just had a bit of an outbreak, and it was related to a nightclub bar.
Very popular bar. Mm-hmm.
Yeah, and so there's, I think, 24.
It's real. So we might have mask fatigue, but the virus doesn't have fatigue. The virus is still going strong. I heard a great analogy somewhere today, and that is wearing a mask is kind of like drinking and driving. You may have a few drinks and drive. You may not kill yourself, but you're putting other people at risk. And that's really considered. This is not perfect, but it is the best we have. And a lot of the literature is suggesting that the real breaking point of communities controlling the spread is how compliant that community is with masking. That is the yin and yang of the whole thing. So please, people, as tired as you are, it does make a difference. It doesn't absolutely guarantee anything, but it does make a difference.
Absolutely.
Okay. Next question. Is it true type O blood is less susceptible?
So is type O blood less susceptible to COVID-19 infection? There was one study that said that maybe blood type. The interesting part is it didn't say that O was less. It said that people that were A were slightly more likely to get COVID-19, and that came out of the United Kingdom. And I don't know their prevalence of the blood typing. So when we look at deaths, there has not been a disproportionate amount of people that are O, A, or AB that have had a blood type with death. So it's nothing you can change or do anything about it. And as far as we know, it really does not impact your rate of morbidity and mortality.
So certainly based on your blood type, do not base your risk based on what blood type you have. I think that's the take-home message.
Yeah, you're not protected if you're not one of the blood types. Yes.
Okay.
The next one is about the map, but I don't think we had it up today. Where in the county are the recent new cases? All
over the place. So yeah, as we look at that map, what what my informatics person and I do is we about once a week or every other week, we take the numbers and we compare them to their population density, and we look and say, are there any areas in the community that really seem to have a disproportionately high number? And of course, when we look at certain places like East China that had the nursing home, we had to extract that. And the answer is no. We have not found any community that has more cases relative to the number of people that live there than another. There's slight variations, but again, sometimes if you have a community of a very small number, 2 cases can end up being a high proportion. So we are watching that. I can tell you that it is really just all over our community, and the risk of you getting infected is not based on where you live. It is based on what you do.
Exactly.
Okay, it is based on what you do and whether or not you breathe in the air of another human being that has COVID infection, whether you know it or not. And that's the risk. It is not where you live, for now. So, okay.
What about playing competitive softball this summer? Is it safe to do that? Leagues are starting in a few weeks.
I guess that's one of mine. So, is it safe to play competitive baseball? Let's say, is it safe to play any sport, competitive or otherwise? I just mentioned that the risk, we know that the risk of getting COVID is related to breathing in somebody else's respiratory air that has COVID in it. That breathing in is dependent on how long you breathe it in and how many viral particles are in that air that you breathe in. So outdoor activities are intrinsically less risky than indoor because the air circulation will dilute the amount of viral particles at any one time that you breathe in. So sports that are outdoors, a little better. Sports that don't require a lot of close, face-to-face breathing back and forth are a little bit harder. And so when you are playing a sport, those are the things you're going to pay attention to. Baseball, intrinsically a little easier to do, right? You got to be careful in the dugouts, but most of the baseball field, people are spread out pretty wide. And then again, bringing up how long you're close together. So if it's a few minutes, you're passing each other, maybe okay, but if you're sitting, like if you're like this all the time, like in a football huddle, right, those are the things that are going to be a lot riskier. We're going to have to figure this out. There is no such thing as safe. There is risky and riskier. It will be risky to play sports and be out in a group of a bunch of people together. But there's things you can do to make it less risky. And that is just the decision people are going to have to make.
Right, and so like for softball, they have to change the something they're going to do, right? So they don't sit together in the dugout, they've got a space.
Right.
Sometimes in sports, 2 people will be a little agitated with each other about a call. So they'll be face to face, maybe a little bit of arguing going on. Well, some spitting happens. Mm-hmm. Well, that's a really high risk environment. So those kind of activities are going to not be going on, at least they shouldn't be at this stage of the game to get back to the sport. So to make sure that we're distanced, again, softball and baseball, there is some spacing that's possible, but they have to alter behavior so they're not doing the high risk procedures or activities during the sport event.
Oh, and here's the other thing. We know that athletes play no matter what. The game must go on, right? And we do all kinds of things, especially those high-level athletes. In this kind of a situation, in our current environment, if you're ill, please don't go and play. Stay home. You're putting the rest of your team and everybody, all the people who are watching, more at risk. So that's an important component of a little bit more attention to that. If you're feeling achy and poor, that's probably not a good day to go and participate.
And remember, with COVID, the symptoms are variable. If you think you just have a really mild cold, you probably have COVID. So the thought would be is that in the past, you may have gone and done some things, it's just a light cold, but now assume it's COVID, think you have COVID if you have mild cold-like symptoms, and don't participate.
And if you're not sure,
important.
go get a test. Go get a test.
Yes.
That does help everybody understand better what's going on. We've had many cases where there's been a couple symptoms, no fevers,
right.
And they went a while because there was no fever, and they were positive for COVID. So please, people, just have that low level of suspicion. Okay.
Okay, next question. Do you know if the governor is going to extend the no visitation order for long-term care facilities?
Have you heard anything about that?
So the part that I know so far, because Marwood is part of our umbrella, the answer is it's not changing in the near future. It sounds like because the long-term care facilities are such high risk, as are the prisons, anything that's that conjugate setting where people are stuck together, She is not going to be opening that up. She's not going to be changing that until we probably hit the level 6.
What about hospitals?
So what's happened at the hospitals, hospital visitation, we have altered that as especially in our community because as we saw in the graphs, the number of infected persons has gone down. When we first had COVID, the difficulty was, first of all, it's novel. So novel is new. Novel means we don't know a lot about it. So we were very draconian or very stringent in our visiting policies. As we have learned more, as we now have testing, as we have the health department that can do testing, we have the ability to allow more visitors. So we have allowed now some limited visitation. So at McLaren Port Huron, what we're doing is on the pediatric unit, both the parents can be there. On the OB unit, the father of the baby and a surrogate of some type that may help the mom or her mom or somebody is allowed. We're allowing 2, which we only allowed 1 or none before. On our general medical units, we're allowing a visitor at one point in time and 2 visitors per day. So we've
Opened it up.
Open it up some, and we screen everybody that comes in. So every visitor that enters the facility will be asked questions. Are they having a fever? Do they have a cough? Are they around other people that have COVID? And certainly if the patient has COVID, they have no visitors. That is not just our policy, that's everywhere at this stage of the game. We're still not trying to have COVID visitors to then be able to spread the virus through the facility.
Okay, there's more questions about the blood types, but they can re-watch the video to see your explanation on that.
Okay.
What is the average age of those who have died?
Oh, we've done that before. A big question is, what's the average age for those that have died? We're going to pull that up, and I believe the range is late 40s to early 90s.
But that mean median, I think, is 78.
It's in the 70s, and we'll look that up. We'll get right back to you. But it is on par with what we expect and what we're seeing throughout the country.
Yeah.
Older people and people with other underlying health conditions are clearly more vulnerable to serious impacts of this virus.
When Brandon's looking it up,
Mm-hmm.
Someone asked, are we addressing any businesses like gyms that may have opened despite the state orders?
Okay. So this is a really hot topic in public health, and actually I have a 4 o'clock, we're talking about this on a regular basis. The question is, when people are non-compliant to the governor's orders and kind of doing what they want, is paying any attention. You know, this is like a ping pong match. Court orders them closed, and then they open up, and then, you know, they overrule, and then there's appeals. Well, we just had this with the gyms, where the gyms were declared to be open, and then late last night, I don't know which court system said no, the governor has that right to close them. What we do as a health department is we take those complaints. So go ahead and bring us those complaints. Once we know about them, because we live in our own bubble too, most of us are not going out and doing these things. So we rely on your reporting. Give us this information, and we do in fact reach out and talk to the business owner. There are pandemic plans that are required. If they're clearly out of compliance, we let them know that. And right now, this is that's the approach. We don't have access to a lot of legal, financial situations. By the time we did that, the orders would probably change. So we try and just get people to be more compliant by just talking with them. But we do want to hear about it. So if you have a complaint, we're more than happy to take it, and we'll respond to it the best we can. And don't go there, by the way. Don't patronize it. If you know that they're out of compliance and they're not doing the right thing, don't patronize them. And I think that's an important factor. They're in business, and if people don't want to put their health at risk, don't use that.
You kind of covered this, but is a fever a required symptom to be diagnosed with COVID as well as a positive test? Is this a reliable indicator to enter the workplace?
All right, so I'll take that one. So is fever required to have COVID? And kind of we touched on, the answer is no. We know people that are ill enough to be hospitalized with COVID. Fever is a common symptom, but there are many people, up to 80%, will have no fever and they'll have COVID. So as far as getting back to work, people who are asymptomatic, it's kind of up to the employers what they're doing. I can tell you some of the local employers, what they've done is that their employees wear masks when they're going in and out of work. If they can be at a workstation that's 6 feet apart from other people, they're not masking during their work hours. What other people have done is that if they're in a work environment where they're close to the next worker, they're putting up plexiglass screens between people because of the way the work is put together. So it's kind of up to the employer to make sure that they have a safe environment for their employees when they're bringing them back. As far as the employees themselves, most employers also screen. They're checking for the fever and the symptoms that go well with COVID, including nausea and diarrhea.
So yeah, just so from a health department standpoint, if you get a COVID test and it's positive, we use that 10-day, 3-day rule, or as Dr. Brooks said, if there's reasons why you need to be retested, making sure that your retest is negative, usually times 2, 24 hours apart. However, if you don't get tested and you feel like you've got COVID symptoms, the safest thing to do is still wait those 10 days. If you go though instead and your doctor says you don't have any infection at all, this is just your normal allergies, then at that point, and you have no test to suggest you have COVID, you go back to work when you feel better. I would say as we continue to go through these periods where we're really concerned and we know the symptoms are so vague, if you feel poorly, the best thing to do is get tested. That guides everybody's decision making quite a bit more, and if you can't get tested, if you can, stay home for that 10-day period. That is the safest approach that I can indicate to you.
Agreed.
Okay, next question. Are there any new or emergent treatments for COVID-19, or any of them being used locally?
So are there any treatments at this point in time that are emerging? So what we can talk about is there is an antiviral or a medicine that works against viruses. It's called remdesivir. We have that. We have it locally. The hospitals all in town have now been able to get it through emergency supplies. We do have availability. So remdesivir is a pretty amazing medication because it's an antiviral. And it does work, it looks now relatively well against people that are modestly ill with COVID. One of the things that we're learning is to try to use it a little bit earlier, and we're seeing some better response. So yes, we do have that. We've already instituted at all the hospitals in town. You may have read about dexamethasone, which is a steroid treatment. So we have instituted that. We were actually doing a version of that, actually a bit earlier than this, but now we actually know a good dosing range, so we've been doing that. Colchicine has just hit the scene. Colchicine is really a drug for gout, but colchicine does have anti-inflammatory properties. It works on the immune system to reduce inflammation. In patients that have moderate to severe COVID-19, we are now starting to give them some colchicine, which is starting to show some improvement of their morbidity and mortality. So that's the newest thing that just popped up this week. So we're actually doing that also. So yeah, some new things. People want to know about vaccination though, because that's also treatment. So as far as vaccines go, you know, there's lots in the news, there's lots of excitement. There's, I think, now 8 candidate vaccines in the United States. There's some in other parts of the world. We have one that we're working here and the United Kingdom together, which actually is probably the most promising of the vaccines. The difficulty we're seeing, though, on the 2 most promising vaccines is it will be a 2-dose injection, which does create a more difficulty. Like for hepatitis B, you get 2 doses. It'll also look like the same thing. Timing, that's really a big question. We know that the government is distinctly involved in this and they're trying to ramp up facilities. So if they do get a good candidate vaccine, trying to make as many units as they can, as quickly as they can, and as safely as they can to ensure that people can start to get vaccination. Because there's no doubt in all of public health mind that if we can get an adequate vaccine, it's going to completely change this disease. Some of the data that we have so far is that there may be some mild strain variations of the COVID, but it looks to be pretty genetically stable. So it looks like once we get a vaccine, it should be effective over quite a bit of range of time.
So more to come.
Okay, we have a marijuana question. Are you seeing the use of, do you know if smoking marijuana helps lower the chances because of the THC and the CBC components found in it?
Have you heard this? So the question is, does marijuana or any of the components of marijuana in any way increase or decrease your risk of COVID? I have not heard that. I can say that smoking anything is bad for you. It is, and I would suspect that your immune system does struggle with marijuana use. John, do you have anything more to?
So the thought would be is that people who smoke anything, since COVID is a lung infection, people who are smokers of any type have a much worse outcome. And that's one of the things that we've seen in all the people that have died. If they're obese, if they have diabetes, hypertension, or smokers, their risks are much greater for morbidity and mortality. Now, CBD itself, I have no data. There are other ways to get CBD into the body. Certainly, that would be something to be considered if that's something somebody's thinking about. But smoking it from that point of view, to me, would be an increased risk.
More to come, I'm sure.
I'm sure, too.
Last question, believe it or not, it's already 4 o'clock. But at McLaren, are you using high flow oxygen instead of ventilators if the patient is not critical?
So the question is, are we using high flow oxygen? So what we can tell you is that back many, many weeks ago, some data came out that people who are ventilated maybe didn't do as well as people who were getting high flow oxygen instead. So our goal was to use different treatments. That's when we started some steroid therapies. We had some remdesivir. We had the convalescent plasma, and then changing how we were giving people oxygen supplementation. So instead of intubating them and putting them on a ventilator, we were using high flow oxygen, and many people never required intubation and being placed on a ventilator. So across the country, that's been happening, and if you see some of the data, you'll see number of people on ventilators is actually down because there's a different approach.
Because we're managing them better.
Correct.
So the
We've
longer
learned.
you wait to get infected, the better off you're going to be. That's the other benefit. We keep the curve low so the hospitals can keep up, but the longer you wait to get infected by doing the right thing, the better our treatments. Our doctors are going to just know a lot better about how to treat you. So
Exactly.
it's a good thing to keep in mind.
So closing comments.
Yeah. Well, that's my closing comment. It makes sense to avoid getting infected for as long as possible.
Yeah. So then, wear a mask in public, keep your social distancing, hand hygiene. Those are all things that are really important that can prevent you from getting COVID. And then don't forget flu is coming. So we got to think about that too in the next season.
Thank you everyone for joining us. Stay healthy.
Good day.